I'm going to tell you a little bit about a piece of work that we've been working on for quite some time, actually. And it's lovely that it's now been published at the Annals of Family Medicine. And I look forward to kind of getting your questions and thoughts about what next. I think team-based care is a topic that's really close to my heart in primary care. I work in a team myself. I know that team-based care is a key component of the patient's medical home, both in Canada and the US. It's also recognized as one of the key building blocks of high-performing primary care. There is growing evidence, and we'll talk more about that teams can deliver better outcomes. But policymakers at the same time, many of them are still hungry for more evidence. And it's clear that, despite the evidence that's there, different jurisdictions haven't been able to move towards having all patients be part of team-based primary care and scaling up team-based primary care for all. The work that we did was really to try and build that evidence base using the experiences in Ontario. In Ontario, we've had a slew of different primary care reforms over the last 20 years. Prior to 20 years ago, most doctors were paid fee-for-service, working independently, usually not in a team, but 20 years ago, the government introduced new patient enrollment models. So these are new models that where physicians had to formally enroll patients. Physicians were asked to work in groups together with shared after-hours obligations and coverage. And then the payment of physicians changed. So depending on what kind of model you entered, some degree, somewhere between 10 to 15% to maybe even up to 80% of your payment was by capitation, with some portion of your payment being the rest being fee-for-service and a small portion being by incentives. And then for some of those physicians who went into more of a capitated model, they had the option then joining a team-based model. And in a team-based model, the government of Ontario paid for other health professionals who would be part of the practice. So this could include nurses, nurse practitioners, dietitians, social workers, pharmacists, and more. So this is really documenting that growth of different models in Ontario over time. And what we see is this taking us to June 2019. And what we see is by June 2019, about 11 of the 14 million people living in Ontario are part of one of these patient enrollment models or new models of care. And about roughly a third of them belong to a family health group, which is a largely enhanced fee-for-service model. And the remaining 2/3 are in a capitated model, with about half of those being in a family health team, which is a team-based capitated model, and the other half, what's in so that's the light blue at the top, and then the purple would be the capitated model without the team attached to it. So our objective was really to focus in on that added value of teams and how did being part of a team impact specifically emergency department use for the patients who were belonging to that team-based model. And, for context, these Ontario reforms, they spanned about 20 years. People could enter a team-based model anywhere from about 2005 to 2012. So physicians could enter during that time. And it was voluntary, and the type of team was, of course, heterogeneous as well. So we did our best to really try to tease out that specific impact of the team. And the way we did that was really trying to compare people who transitioned from an enhanced fee-for-service model straight to a non-team capitated model versus people who transitioned from an enhanced fee-for-service model to a team-based capitation model. So this is just a pictorial representation of that study design. We used linked administrative data housed at ICES in Ontario. And our study spanned a large time period. We basically looked at anybody who made a transition to either the team or the non-team capitated model between 2006 and 2013. And we we kind of did a before and after look, including at least 3 years before and 3 years after for any patient whose physician transitioned to that team. And as I mentioned, we compared these two groups, those who transitioned to a team versus a non-team. We did a patient level analysis. It was adults only. And we did stratify by rurality. And our main outcome was the emergency department visit rate. And that was, we looked at the emergency department visit rate before that period of transition to either the non-team or team-based capitation and after. Our primary analysis was really comparing the team and the patients ED visits in the team versus the non-team, and then adjusting for potential confounders like age, sex, neighborhood income quintile, immigration, comorbidity. But we then did a sensitivity analysis where we actually, instead of adjusting, we matched the patients by their characteristics. So we matched for every patient in a team-based who transitioned to a team-based practice. We found one in a non-team-based practice. We were able to match on a number of different characteristics. So we chose these two different ways of trying to answer the same question. So what did we find? Overall, we looked at, big cities, small towns, and rural areas. And, most people were living in the big cities. And we compared in that context 1.4 million people who transitioned to a non-team practice in a big city, and about 400,000 people who transitioned to a team-based practice in a big city. Most patients, physicians transitioned to the new model by about 2010. And the peak year of transition was about 1 to 2 years later for non-team versus team-based practice patients. So this first graph really, or sets of graphs, really shows the unadjusted mean emergency department visit rate in the three strata. So big cities on the left, small towns in the middle, and rural on the right. And what we see in the light gray are the patients that belong to physicians who transition to a team-based practice. And in the black, we see the physicians who transition, the patients whose physicians transition to a non-team-based practice. And what you can see is that the ED visit rate, and then I should say on the x-axis, you see the year 0, and the year 0 is the year of transition. So the year that transition happens. So we tried to line up, no matter whether your transition was 2006 or 2012, we lined it all up to be year 0. And so what you can see is that pre-transition, patients who ultimately transitioned to a team actually had higher ED visits. But then we see that kind of increase blunting after year 0. Whereas, when we look at the big city one, we can see pretty clearly that the ED visit rate prior to transition for those patients who went to a non-team practice was lower, but there wasn't that same blunting of the ED visits, and they continued to kind of increase. I'm now going to show you, this is the adjusted model. So where we've adjusted for things like patient age, sex, income quintile, et cetera. And again, I think it's probably easiest for us to just focus on the big city graph, which is on the very left. And what you can see here pretty clearly is that a similar pattern where we have the ED visits for those who transitioned into a team-based model blunting after year 0. So still increasing, but increasing at a lower rate. And the increase in ED visit, a much higher rate for that black line, or physicians who transitioned to a non-team-based practice, to the point where really, the non-team-based physicians, patients had higher ED rates at the 6-year post-transition mark. So this is our model results. And so the key number here is that really the emergency department, the difference between the emergency department visit rates in the team versus the non-team was about 2.9%. So the team-based practices, so what that means is that we see that we can look at the trend in annual rate after transition. And that's what I was showing you on the graph. And in the non-team practices, that was 5.2% increase in emergency department visit rates after transition to a non-team practice, compared to 2.4 in team-based practices. So that's a difference of 2.9% between the non-team and team-based practices, where we see the change in annual ED visit rate was 2.9% higher for that non-team group compared with the team group in big cities. So I mentioned we did a sensitivity analysis, and the sensitivity analysis essentially confirmed the same results. So here is where we matched instead of adjusted by patient characteristics. And you can see a similar kind of pattern in that big city graph on the left, with teams this time in orange and the non-team in the dark blue. And again, we see the team-based ED visit rates after transition blunted, whereas the non-team visit rate continues to kind of increase at a higher rate. So in summary, we found that in Ontario, patients who joined a medical home combining capitation and team-based care had slower increase in emergency department use compared to those whose physicians transitioned to a capitation model without a team. Importantly, we found these results were consistent by rurality and even using two different methods. We used data from all across Ontario, and this was, of course, real world data, and we had outcomes that extended actually quite far after people transitioned, which I think is one of the key strengths of our study, because we know it takes time for these teams to gel and for improvements to potentially be seen. Our limitations, of course, though, are that the teams in Ontario are heterogeneous. So, for example, one team, may have 4 social workers and 3 pharmacists. Another might have, very few pharmacists and more social workers, or not even very many, and have more nurses instead. So the composition of the team, the roles they play, the turnover and the function of the teams is different across Ontario. And we weren't able to really tease that out or unpack that. So it's unclear what aspects of the team were potentially most effective. And then, of course, we know that ED visits are just one of many outcome measures. So I think our study really builds on previous data from not just Ontario, but other jurisdictions as well, that show that team-based care produces better outcomes. In Ontario, there's data that show, real great patient satisfaction, high levels of patient-centeredness. In particular, some of the previous work we've done has shown that, patients in team-based models have greater awareness of after-hours care. Other work that we've done has also shown that patients who've been part of teams and have diabetes are more likely to get recommended diabetes care, and have actually experienced more of an improvement in being able to get that recommended diabetes care. And then, of course, our study really adds to that part around healthcare use and the impact on healthcare use. But despite this growing evidence, unfortunately, we still see that the expansion of teams in Ontario and elsewhere has really stalled. And this article that I'm sharing here, I think it's about 6 or 7 years old now, and it really delves into these, why is it that the Ontario government has shifted away? Certainly, some of it was related to perceived cost and perceived value. And my hope is that our study, along with other studies, add to the growing body of evidence that can convince policymakers that this is a direction they should continue to take. But importantly, I think this evidence around impact is just one factor. The other factor I really think is values. So now at this point, we have, as we saw, 20-25% of the Ontario population at best having access to team-based care and free access to professionals like social workers and pharmacists, and others not. And that's simply unfair. And it would be less unfair, I would say, if the teams were distributed equally across Ontario in a way that made sense from a population need perspective. But instead, the distribution of teams is kind of akin to the inverse care law, where we see that actually high needs areas, both in the inner city and in northern Ontario and rural Ontario, are actually those high needs areas are less likely to have a team. So this is some fantastic work done by one of my study co-authors, Rick Glazer, where he and his team looked at that variation in access to a team across Ontario and saw that variation wasn't proportional to need. So in short, I think our study adds to the growing evidence that team-based care means better care, and in particular that team-based care coupled with payment reform may reduce emergency department use.